in those patients, and actually in practice you see this. And I think from this, it led to the endovascular vein harvesting. Endovascular vein harvesting, as you notice here, it's a longitudinal incision. It's all across the leg, and the endovascular, it ends up with a small 3 little incisions, maximally 3 centimeter in length. The points against open harvesting, it's a longitudinal incision, as I mentioned. The vein has uncertain course, ending with maybe flabs, poor healing, and the average incision is 20 to 40 centimeter in length. Poor healing, especially in the diabetic patients. The infection rate for those patients is overall is 1.5% before discharge. 30 days is 4.6, and it goes up to 7.3 in 90 days. 80% of these infections, you can see them unfortunately in the clinic. The advantages of endoscopic vein harvesting, it shows decreased risk of infection, and this is all proposal, and I'm gonna prove it later on with the studies. A decreased risk of infection, decreased wound complications, decreased post-pain, swelling, and decreased length of stay. These patients will have a faster recovery and minimal scarring. The procedure is single incisions, maximally 3 centimeter in size, with this at the knee. And with this, you can go proximally and get 35% of the vein as a length, and distally as 35 centimeter also, ending up with a 70 centimeter easily, which is enough almost for 3 grafts, plus the memory, of course. The point against it is a learning curve. And you need 20 cases at least to have this. But I'm going to show a study later on where this point can be also criticized. Now coming to the advantages of the endovascular vein harvesting. First of all, the non-infectious problems. And with this, it's 27 studies included almost 5,000 patients. They analyzed 12 randomized control, and it showed reduction in the AVH group to 4% from 13%. The wound infections, which is devastating, 11 randomized trials were done, included almost 1,000 patients, and showed also reduced infection from 13 to 3%. The postoperative pain in those patients, in the AVH group, it showed 2 lower pain scale, which is from 0 to 10. Those patients were mobilized also earlier, and the freedom from pain was days before the long leg incision. Hospital stay, these studies showed there is almost 1/3 of length stay reduction. This is also included with almost 1,700 patients with confirmed also lower stay in the hospital. The cosmetic results, of course, you have a long incision and 3 small incisions, which showed that the satisfaction of the patients will be good. However, having said that, at 6 weeks, both groups are equally satisfied. One critical point is the durability in AVH, and this because of the thermal injury, CO2 inflation, and microscopic clots. The microscopic clots can be treated by giving the patient, before opening the leg, heparin 5,000 or 2,500, and this will prevent this. Also, irrigation of the vein. And I do personally, I divide the vein into the into the parts which I'm gonna graft. And with this, you decrease the clots in those patients. But I'm gonna show studies where it showed that the durability of the vein is even better. And with this study, this is confirmed by even CT scan that showed that it's really comparable and it's good. Regarding the symptoms, recurrent angina or this is one of the studies, and this is multiple studies here, which showed that the patients were followed from 3 months to 5 years, which showed there is no significant difference in the recurrence of symptoms and durability of the vein grafts. I have to say that the durability of vein grafts improved markedly in recent decade, and this is because of using antiplatelet therapy and controlling the lipids, and this will improve the quality. I'm a vein person. I am single and 3 veins. As Dr. Muhammad Nasser said, Clinton received this. This study, it's a randomized control study. It's a small group. It's like 50 patients in each arm. The demographics of those patients is the same, and the surgical outcomes also showed it's to be the same, and the ICU stay and all this is also non-comparable, and there is no significant difference between the 2 groups. This is the conclusion. This is also one of the best randomized studies I've seen in literature, where they randomized 700 in each group, and it showed that the infection rate is significantly lower, and it's almost less than 1% in the AVH group. Short and term patency is similar, and the risk adjusted is also similar. And this study really confirmed that both the AVH really is as good as open techniques. As I mentioned before, that there is a learning curve. This is an interesting study where they did 30 patients, and they compare it to the other 30 patients in another group, and they followed them with a patency rate in both groups. And this is in a hospital where they started AVH. And they concluded that there is no difference in patency time. So learning curve is good, but if you are a starter, even for a beginner, it's as good as open technique. This study summarizes everything about the incidence of wound infection and graft patency with a 30-day mortality. In wound infection arm, I cannot point it here, or I can. The mouse? Yeah. In wound infection, anyhow, in wound infection, the open technique is more, as we confirmed that, especially in diabetic patients. 30-day mortality is equal, and graft patency, it's only measured in 3 studies, which showed to be equal. This is a video, and from the beginning you think maybe it's a thigh, but it's actually a leg. And this is showing that the vein is almost taken. We also took bifurcating veins, and this is, we used it for as Lima and the 3 grafts. So we use this for 3 grafts. This is a courtesy from King Salman Heart Center in Riyadh, where they did a study about the AVH. I wanted to notice here that the incidence of diabetes is almost 85%. So most of our CABG patients in the kingdom are diabetic. The other thing is there is 0 incidence of Lego infection. Actually, if you want to say that there is 1 patient developed wound infection, and this patient particularly was converted to open procedure. In conclusion, AVH provides reduced morbidity, reduced recovery time. The quality of the conduit is almost reserved. There is less wound disturbances and infections, less postoperative pain, and it's beneficial especially for diabetics. And I have to say that there was a paper, I just read it recently, but I didn't have time to prepare it on a slide, where they studied almost 1,700 patients, and they did risk adjustment, what I mean, including diabetics, female gender, and peripheral vascular disease. And they found in this study, if you do the open, the infection rate is 20%, and if you do the AVH, is almost 4%. Thank you very much.